Good morning, good afternoon, and good evening, our dear colleague. Another exciting MOH Connect event. I am Dr. Muhammad Omar Farouk. I'm a consultant vascular surgeon. I am delighted to be accompanied by two of the most eminent philippologists worldwide. And this time we're going to learn from their clinical experience about a topic which is very near to all our practice, which is ultrasound-guided sclerotherapy. Let me introduce my first speaker, which she doesn't need introduction. She's worldwide renowned international philipologist, Professor Erika Mendoza, and she is mainly have venous interest, specialized with duplex ultrasound. She has her own philosophy, strategy, and books in that field. She is one of the great advocate for Chiva procedure, and she's also was the General Secretary of the German Philipology Society. She's also have multiple workshops in Germany and of all international meetings. She is the General Secretary of German Society of Philipology since 2015. She played a great role both in COVID and post-COVID, and we're going to enjoy a live cases with her with a ultrasound-guided sclerotherapy. I have the second, the very eminent speaker, Joseph Grace, but I will leave if Professor Erika Mendoza is ready to start, because Professor Joseph is going to give us his pearl experience, quite astounding panelist with us today to tell us a lot of tips and tricks about this technique. So back to you, Erika.
Okay, so let me start. Thank you again for this wonderful moderation, and thank you, Sigvaris, for doing this this event. This is obviously supported by Sigvaris. That could be a conflict of interest. Indications for ultrasound-informed sclerotherapy, I will make it very short in my eyes, and if you look at the current guideline of the European Society by Marianne de Mezener, which is gorgeous, you have some important indications for foam, ultrasound-guided foam sclerotherapy, which is the saphenous vein insufficiency, the recurrent veins after high ligation and stripping, perforating vein, and I added transtibial, as you will see in the case. If you are treating saphenous trunk incompetence with foam sclerotherapy, and we have to think about countries where they don't have the ability to go to surgical theaters just for treating saphenous veins sometimes, you may do it also with foam, but it is recommended to do it with a diameter less than 6 millimeters. And it is a pity that this is not said where the diameter should be 6 millimeters, because we know that at the groin, it is always larger than a medial thigh. But if you take it as an orientation, you might find your way. And which is changed after studies having been performed to that point, is that patients with superficial incompetence undergoing ultrasound-guided foam sclerotherapy, as I've always done it like this for all the patients, but here, especially for the saphenous trunk treatments, it is recommended to put post-procedural compression. And I think this is really important because I'm sure it reduces also the discoloration of the skin, which can appear after the treatment. And so I think this is a very good recommendation. This is, of course, repeating that if you do a treatment of foam sclerotherapy, you should use the ultrasound, and I think not only during, but also before. You need to make sure what you are treating. You have to make a plan. The patients we see today, they are already made the plan. I just will show you before doing it the key points, and then we go right ahead treating them. And what is the most important reason for me to treat ultrasound-guided foam sclerotherapy are patients with recurrent varicose vein, because going back to an already intervened region with scars and so on is much more hazard to the patient than if you give ultrasound-guided foam sclerotherapy. So this is just to see the skills, but not a learning course. If you want to learn, you have to be able to do a proper ultrasound, weeks and months of learning. You need to know how to handle foam and so on. But I just want to show you what is possible. It is always important to make the anamnesis of the patient and investigation. You need to decide about concentration of foam sclerotherapy agents and the diameters and the flow velocity. We will see that come to this point and help you deciding this. And then you have to manufacture the foam. And we are going, just please show my other camera, because I will show you how I do this in my office. Do you still hear me when I move? Just when I'm here, do you still hear me? Do you still hear me?
Yes, I can hear you.
Yes? Okay, thank you.
Yes, we can hear you very well.
We have inside a three-way connector.
Yes.
Obviously, you do it with gloves, but now for the demonstration, I don't. You have two large syringes and one little one, and my colleague hands me over a foam of 1% etoxysclerol. And thanks to Joseph Grace visiting me, I now always use blunt needles, avoiding stickings. And I have 10 milliliters. I put 2 mils into 10. This means I have a concentration of 20%. I mean, one part liquid and 4 parts air. Then I put this together, and you can start doing it just in a completely open way. But the trick is, if you close it a little bit, yes?
Yes.
If you close it a little bit, then you will have a better foam performance. And then you will hear
Excellent, yes.
the noise performing the foam, and you see already the foam is there. And then
how many times do you need to do this?
I take just little amounts of 2.5 or 2 mils, because the German guidelines says you can't apply more than once 2 mils inside the patient. So just to avoid me to overdose, each time I make a puncture, I will use this way to do it and to observe. And then show here, then the foam is quite good, as you see. And this also makes me manufacture the foam for every new puncture. And this makes me have good foams straight away. Because if you would use the big one, it would get spoiled in the time. What I want to show you, I think everybody knew this. Of course, I use little needles, and if I have spiders, I use less, the yellow ones. But now I want to show you something I learned from my friend Massimo Capelli, and this is, if you see it here, I have put 1 mil, yes, 1 mil of 3% etoxysclerol in 8 mils. In 8 mils, this is a little bit more. Yes, no, it's perfect. In 8 mils for air.
Okay.
The total is 8 mils, so I have 7 to 1. And this is the dry foam, because you have more air in relationship to only 1 milliliter. And if you make this foam, you will see that I again use a little syringe to. You will see that it is far more solid. You can make amounts of it. You see, it is really hard. No, it went. This is a perfect foam to be used in large veins or next to the deep veins, because it advances very slowly. And we will use this also in our patients today. So this was my way of manufacturing. I think that this preparation with one package for everything I need is a ecological way of avoiding too many individual wraps for opening. And yes, and I go back to my camera, back to you.
That is excellent, Erika. Thank you. Do you have any comment, Joseph, until she goes to?
Now I'm going to change a bit and give the mic to Joseph, because from Joseph Grace, I learned a very interesting thing when I visited him in Australia. And this is that he performs the ultrasound-guided sclerotherapy in large veins, adding perivascular
infiltrate.
Yeah. So let's
Oh my
take
God.
this
Yes, he will
opportunity
tell you.
of
He will tell you, and I will get changed and bring a patient in the room.
Brilliant.
Thank you.
So this gives me the pleasure of introducing one of the most eminent phlebologists worldwide from Australia, Professor Joseph Grace. He is a phlebobologist and vascular interventionist. He's also senior lecturer, Faculty of Medicine on South Sydney. He has really a fascinating CV with a huge amount of activity and research and venous workshop and venous symposium and venous intervention. Currently, he is PhD candidate in research of physiochemical properties of medical adhesive and the human tissue interaction. Very exciting topic. Is also very well known for his papers on phlebology and fluid mechanics with the University of New South Wales. He's also have a lot of information about health care in the public sector with a lot of ethical and a lot of exciting field in that field. Is going to squeeze to us his 20 years experience or even more in using sclerotherapy. So it is really a privilege to me to introduce Joseph to all of us, and we're eagerly waiting to hear you, Joseph.
Well, thank you very much, Professor Amar. I'd like to thank you for your kind invitation and kind words. In addition, Sigvaris has been tremendously supportive, and this MOH program is a testament to that. A kind gratitude to Mahmoud El Gadban. He's been the inceptor and has always kept us up to date. So, my dear colleagues, professors, doctors, and lifelong friends internationally, it's a pleasure to be joining you here in Sydney. Or from Sydney. I thought I would first say thank you so much, Dr. Mendoza, for showing us your foam sclerotherapy production. I can't emphasize the importance of simplicity when looking at such a technically a complex procedure. It is so important to have your medications set up and ready to go. It's essential that we recall and understand that we're actually manufacturing a drug when we're using foam sclerotherapy. So by simply going from a solution to microbubbles, we have actually manufactured a new drug. And technically, we still remain using this form as an off-label use. So do you use STS, or do you use ethoxysclerol? Do you use air? Do you use medical CO2 gas, oxygen, etc.? I think that is open and entirely available to preferences. My personal preferences of having performed ultrasound-guided foam sclerotherapy since 1995, I would say with a high degree of certainty that it is essential that you develop a profile and that you actually keep your processes as simple as possible. Because remember, you'll see shortly when Dr. Erika commences the treatment, firstly, the patient needs to be worked up. Secondly, the The procedure is being performed in the dark. And thirdly, you may or may not have the assistance. So thank you so much, Dr. Erika, for commencing with the single most important rules and facts, and that is production of foam. You need to have this efficient, simple, and reliable. And remember, we are actually using it off-label, so we can only rely on consensus statements, both the European, the American, and the Australian. And these guidelines are absolutely essential. We can talk for hours about sclerosant and concentration and whatnot, but for now, I'm going to hand back to you, Dr. Erika, if you're ready to go.
Yes, I'm ready to go. I'm going to share my screen because I have patient, and where is the nipple? What? Mir das abgewiesen, das ist an meinem T-Shirt, das T-Shirt nicht in der Kamera. Everything possible to be gone is gone. I lost the connection to my daughter's bringing it to me. So I share the house. I share the screen with my ultrasound device. Yes.
Yes, we can see your ultrasound screen.
Okay, we do it without a name.
And we can see from your mobile the very kind patient that we like to thank her for.
But you see me also?
And we see you as well, yes.
Yes, and I have to change this, like this position. There was something missing. I'm getting older.
A real expert in live video streaming, Erika.
But I'm getting older. It's every time.
Younger, I think.
We have a wonderful patient here, Miss Newton. Turn around there. More. And you see here you see here the varicose veins on the back of the leg. Can you please, perhaps with the camera, come here? And did you find no? Okay. You see the veins here on the back, and we now move the external camera to see better what we are doing. Drehen sich noch mal zum Fenster hin. Here we see.
Yes,
you see
can
in
see
the
it
extra
now,
camera
yes.
the image. So this patient really has not recurrence or a complicated. Oh, I found it. Or a complicated situation of the deep veins or perforating veins, but I just wanted to show elemental. I'm too stupid today. I have an ultrasound. So we go right, storing the target zone. Perfect. Thank you to my daughter. She needs an applause because she's really helping me. Mama is stressed and daughter is organizing everything. So you see the ultrasound image properly? Better than you perhaps?
Yes, we can see it very well, yes.
Okay, so we have a little perforating vein here on the thigh.
Yes.
And I just selected this patient because of one reason. You tend to make the injection at this point. This is the fascia, this is the skin, this is the muscle. You tend to inject here because you think that you could penetrate better the complete perforating vein, which is the blue one, yes, when you inject it just this level. But remember that you are always injecting in no color mode. And you will not be able to differentiate between the artery, which we are seeing here. Yes, we will inject in this mode, and there is an artery. And the risk of making a puncture of this artery when you do it in black and white and not in color is really high. So the guidelines always say that you have to go for the vein at least 2 or 3 centimeters away from the fascial.
This is very important tip and trick, because if we inject in an artery, maybe the audience would like to know what will happen.
I don't know. I don't want to tell you, But I have to tell you,
Okay.
this is a draining perforating vein. This
Yes.
is not the original one. We have to look here upstairs, here.
So if you happen to inject in an artery, then you will get an embolization to the tissues. So either you get
Yes,
muscle
yes.
necrosis or a skin necrosis,
Yes.
and it can be catastrophic. So please, very, very important, this advice. What do you think, Joseph, from your experience?
Yes, absolutely. I support you entirely. And the answer is, unfortunately, the sclerosant is so effective that even the smallest amount of the scleroembolic entering the arterial circulation will result in complete avascular necrosis. And of course, it depends on the vessel. In the lower limb, if you hit an arteriole, you're likely to lose up to 10 square centimeters of dermis. But of course, it gets worse as you approach the axials. So as Dr. Erika has already pointed out, and you can see there on the screen, you've got a clear, a perfect demonstration of the color Doppler of the arteriole, associated arteriole, and you can see it pulsating right now. What's most important is to stay well and truly clear of that.
And now I have to, I hope that somebody, having learned from last time, would tell this is not a perforator to be treated. Why? It is only draining. You see that? It drains, it is not refluxing. This, I wanted to demonstrate it to you, hoping that somebody would say, but why won't you treat this perforating vein? The lady has a diffuse build-up of varicose veins on the thigh and gluteal region that drain through this perforator and fill all these parts. So really to make this sclerotherapy, you don't need to make it ultrasound-based because it can just go into the visible parts of the vein. But I wanted to start with an easy case just to show the handling of the syringes and so on. And in the next one, we will do the ultrasound-guided. This one, just to make it again, this was such a perfect case with the artery in the perforating vein that I just did want to show you. So now I ask the patient to lay down.
Whilst we're having the patient lie down, Dr. Erika, if I may, I'll just share as well my tips on ultrasound-guided. I like to actually split the screen and show color Doppler on one side and the B mode on the other. So I'm getting a simultaneous view of both. Of course, you need to be careful because it may reduce your frame rate and whatnot, but I have it set up so that I'm simultaneously looking at two identical screens, one with color, duplex Doppler, showing the arterioles, etc., and secondly, B mode playing. And Erika, thank you kindly for also confirming that that is a non-refluxing perforator. I find it quite annoying and frustrating when, you know, you're told or asked the question, how do you treat perforators, when in reality you need to know which perforators, and they're not treated any differently. And as you know, Professor Omar, in your clinic, you may actually have scenarios with quite large perforators. Still, having said that, every perforator, if it is abnormal, will be contiguous with an underlying tributary or trunk or both. And what I advise is that, of course, treatment of the associated abnormal trunk or tributary will address the perforator in almost every single scenario.
Excellent. That's an excellent advice, Joseph. And please jump in at any moment to enlighten us with such a great tip. We're ready for you, Erika. I can see you prepare your
phone. Do you
phone.
see the veins properly?
Yes, we can see it very well.
So there is also a question, do I do I perform the sclerotherapy from proximal to distal, or from distal to proximal? As this is like a fan, it comes from lots of them. I go and inject via proximal. I go inside the vein. I close distal digitally, and I just inject. And possibly you see, gutes Weh, it's okay. That I have, that this one is the color is gone of the vein. Sometimes it makes like fluff, and everybody is like everything is going, is leaving, is flushed with them. Perfect. I will recharge.
How you make sure that you are inside the vein, Erika?
You know, when we used to do liquid sclerotherapy, we could do it aspirating.
Yes.
But with foam, you can't aspire because you don't make a vacuum. You can't aspire. So you can make sure you're not in an artery because it's not pulsating inside.
Yes.
Shouldn't happen. Yes. But it is really, after years of doing it, attention, I will make the next puncture here. You notice when you are inside, and then I give a little bit of the liquid and see it moving along in the vein.
Yes.
As always, when you do it with the camera, it doesn't work as you usually want to. This one is good. This one, you see it moving.
Oh, fantastic.
Flashing
Disappears.
Everything. Yes, and suddenly it stops, and you get intracutaneous, but it doesn't look like. So this segment is already done. And normally I hope to have it done like I puncture here and this all disappears. And so we now are aiming to do that with the next puncture, we will get this one treated. Puncture.
And whilst you're there, Dr. Erika, I think it's absolutely essential to share your needle gauges because of the viscosity of foam sclerotherapy. And
this one was what? Yes.
Would you kindly share your preference in needle gauges for doing foam sclerotherapy on the reticular veins that you can physically see?
Joseph, you know me, and I am the person knowing which colors the things have, but I don't know the numbers. This is
22 gauge.
Number 18 in Germany, and I think it's 22 gauge, but I don't know it. And I use the number 21, which is a very ganz kleine rausholen.
Which is green in the West.
I use the real small one like this. Have a look. This one I use for the spiders.
Yes.
This one I use for larger vessels. And this one is German number 21, but I don't know the gauges. I think it's 26.
Is this the same scheme that you use, Joseph, in your cases?
Yes, I actually definitely use that little yellow syringe, and that's a 30 gauge needle, I beg your pardon. And that is the one that I think you'll find worldwide is pretty much shared. And your brown one is a 22 gauge. Back to you.
Okay. So now you see I have started upstairs. Yes, here. And a little bit of readiness is appearing. Yes. And I've organized to make this segment with 10 mils, which is what is allowed to give in one session in Germany. So these ones I will have to treat in another session. Yes. And sometimes, I don't know what it depends on. Sometimes you give a little bit here and the vessel like contracts and you manage to do the complete leg in one session. But sometimes it doesn't happen. And I don't know why this is like it, because here still in this part, I still see some veins I would like to treat and here. But I think this rest, I can do it in another session. And now,
Yep.
for me, very important, we go on is putting the stocking to the patient. And the patient shouldn't get up before the stocking is on site. So we ask her to turn around on the back. Don't miss the wonderful tattoo of the lady, internationally known. And we have this kind of device to put the stocking prepared on it. It's a Medi Butler. I'm sorry, Sigvaris, but this one is from Medi. And we can put the stocking to the leg, just putting what's the name of this in English?
Gauze.
Gauze.
Yeah.
What?
Gauze.
Gauze. G-A-U-Z-E.
Ah, gauze. Okay, thank you. Go to the leg and the places where the larger veins have been. And it is very important that the patient doesn't get up before we have done this, because we are using foam. And if you get up, the foam goes into the circulation and might go inside the brain or the atrium. And some studies have shown that even if you don't have a patent foraminal valve, you could also have mini bubbles here in this place. So it is safe, for safety of the patient, that we leave him lying recumbent down and wait just for some minutes. So putting the stockings to the patient is a good thing, because these are some minutes we are having the patient, and we never leave the patient alone until he is completely dressed, because the effort of putting the shoes on sometimes can provoke like a little bit of fainting, or that he sees like little dots when he gets up. This happens. I do about 1,000 sclerotherapies a year, and I always say 4 a year happen to have a little bit of dots in the vision field when they come to the front. And this is like a little, I don't know if it's a migraine, perhaps, because it reacts wonderful to coffee. I always offer them a coffee and let them there control the pressure, the blood pressure, and then it used to be gone. So now we go down the table a little bit, ask the patient, is everything fine? Perfect. And she will sit down first. So we observe the process of getting, set up. Okay, alles fine. And then she can go and dress, but we will stay in the room. This is very, very important for me. Vielen Dank. Because earlier we used to leave the room, and I had one lady that fainted after we left the room, and this was not such a good option.
Yeah. I would like to take the opportunity to thank Erika Mendoza, daughter, for a great. She's holding the mobile camera and she's helping us to learn.
Yes, Clara is the best.
That's a great effort. Thank you very much. Do you have a comment, Joseph?
Oh, yes. Look, firstly, thank you, Dr. Erika. And I'd like to take up on your point of either scotometer or visual disturbance, which we do classify as migraine equivalents. And I think it's very interesting that you bring that forward. Clearly, and you're also spot on about giving the patient time, because as soon as they try to bend down to put on their shoes, etc., they're in fact inducing a Valsalva, a voluntary Valsalva maneuver, which we've clearly shown and demonstrated that if there is a patent foramen ovale, that you will be basically almost creating a jet from the right atrium into the left atrium, and hence the purpose and reason for our paradoxical phenomena. And what's also important to note is, of course, that up to 25% of the normal population actually have a patent foramen ovale, and in that instance, give that person a Valsalva maneuver, which is what we use, as you know, when we're doing echography to identify a right to left shunt or an an atrial septal defect, that's the single best way to do it. In fact, Erika, I've picked up this point, having watched and spent time at your fabulous clinic, and I thoroughly agree. In fact, I actually set the stopwatch and a timer of 5 minutes or so, where I have the patient lying completely still with the limb elevated, and I give them 5 to 6 minutes because that's whole blood clotting time. And in essence, if we have injected a sclerosant-induced endothelial lysis and hence commenced the sclerotherapy process, it does not hurt to allow the clotting cascade to actually close and, in fact, help achieve complete stasis within those vessels. So I usually lay my patient down and have them elevated for about 5 minutes. Also, Dr. Erika, I take your point. I love your suggestion about working from proximal to distal, and it actually makes a lot of sense. And that is, it allows you to, in essence, treat following the path of reflux. And that is, if there is no reflux and you treat proximally, the foam will not continue distally. So that's logical, and it's a very powerful and useful strategy to take when applying your sclerotherapy. Back to you, Professor Amar.
Yes, excellent. Thank you very much, Joseph, for this very nice comment. There are 2 questions for you, Erika. Do you like to take them?
Yes, of course.
Okay. The first question is from Dr. Baha Rifai. What is the percentage of foam are you using right now? You wanted to use 1% or 3%?
Yes. No,
And
in
why?
this patient, it was only tributaries that we discussed, and so I
Yes.
took 1%.
Excellent.
Because always when it's subcutaneously and these large veins, I take 1%. If it's
Yes.
spiders or reticular, it depends. I take 1 if they are real prominent, and 0.5 if they are smaller. Then we can discuss the point of foam in reticular veins and in the spiders, because it is
Yes.
always said you shouldn't use foam. The thing is that you destroy a part of the bubbles in this yellow needle, but
Yes.
at the end you are diluting the sclerosant agent with air. And in my
Yes.
eyes, it has two advantages. If you extravasate with a spider, you are extravasating a minimum of medication and air. So the
Yes.
skin lesions are much less since I use foam in spiders than when I used
Liquid.
the liquid one. So
Yes.
I dilute my sclerosing agent as a foam, and then I destroy the foam a little bit with a yellow needle. So it is not mega toxic, but you have reduced the extravasal toxicity, and nobody will tell me that in real little spiders you are always intravasal with your needle. You can't.
Yes.
There is
Excellent.
always a little bit of extravasation, and from my experience, since I do this, I have less like little, when you have an extravasation and just damage the skin, you have like these little things when you have with a cigarette, you make the cigarette out in the skin. Not that I'm used to do that, but these little round lesions that take months to heal.
Yes.
Since I use the foam, I have much least of them.
Excellent. Another question from the candidate. Which compression did you use and what concentration? I think you mean what degree of compression did you use?
I use always, when I treat, the German class 2, which is 28 to 30 millimeters mercury at the ankle. If it is a person that is very old and frail, I use class 1, which is 15 to 22 at the ankle. And if you think that in all the rest of the world, the class 2 is our German class 1, I think that using around 20 will be good, will be fine. But I don't think that there are any comparative studies between the compression.
Yeah.
I think it is very important to put the compression on before the patient gets up to reinforce the emptiness of this vein as long as possible before starting the ambulation.
Yeah.
And yes, this is the...
Okay. And the question from me, you did mention very good point that when you put the foam, the needle, you cannot aspirate blood to make sure that you are inside the blood vessel.
Yes.
But have you used the hockey stick probe with the duplex that can magnify the 1 millimeter and 0.5 millimeter vessel, and then you can actually see the small 30 gauge needle inside the vessel. But your advice is extremely nice, which injects slowly. If you see the vein start to disappear, you're in. If it extravasate, stop, either go back or forward, make sure. But this takes experience. Is that right, Erika?
Yes. I'm doing this since 20 years with this foam sclerosis.
Yes.
And at the beginning, I always was very confounded by the fact that I can't aspire. But first of it, with time, you notice that you are inside the vein because you have a little of resistance and then you are there.
Yes.
This is one point. And the second one really, and not only to make sure you're intravasal, but also because you will have less complications if you inject very slowly.
Yes.
Most of the skin reactions and skin lesions are because you have injected very high pressure, very quick, and then you have the pressure going into the arterial capillaries backwards.
Yes.
And
yes.
you have to avoid that by any means. So always inject smoothly, always. And this helps you seeing that you are in the place.
Yeah. Do you like to comment, Joseph?
Yes, I thoroughly agree, Dr. Erika, and that is it's absolutely essential that you get the pressures right. So, for example, I could easily cite for you an example where I would use 0.12% STS solution in a telangiectasia. But if I use enough pressure, I can actually induce an ulcer. And the way in which that happens is that you're in the capillary vasculature and you're rising the STS concentration or sclerosing concentration in the arteriolar capillary end, which is enough to in fact induce an avascular necrosis. So even if you use the maximum dose in a tiny vessel, but you inject it very slowly and gently with very low pressures, you're going to reduce the likelihood of arterialization of your sclerosing. Point number one. Number two, the other thing Dr. Erika's mentioned there is the veno-arteriolar reflex, which is really quite fascinating. And that is, as soon as we inject a sclerosant or an irritant into the venous system, we're actually getting a venoconstriction and then opening of arteriovenous shunts. And that's how we explain the phenomenon of ulceration at remote sites, not at the site of injection, but at other little sites, when we know we're definitely in a vein. It's purely simply because we're actually reverse injecting and introducing sclerosing into a veno-arteriolar reflex, and then of course the blood is refluxing into that. So the key is reduce your pressures. Back to you, Professor.
Yeah, no, thank you very much. And I think recently there is some paper about they want to train robotics to do the injection for sclerotherapy because they are very accurate. They are femtosecond accurate, and we are very good in imaging. And now, the HIFU machine, you get the image and you get the robotic arm and it decide where to fire the high intensity ultrasound. I'm sure this machine with the robotic arm injection, but it will be very costly. And I got another 3 or 4 questions, very interesting to you, Erika. So what do you like to do? Do you like to
I-
take
I
one
would-
or two and go to the patient, or what do you like to
I
do?
am seeing the questions, and the one is, how long would you put the stocking? And
Yes.
this is
Okay.
very important, and we finish it because it was the first thing we commented. The
Okay.
stocking, I put them 2 weeks. Because
Excellent.
my experience is that it takes 2 weeks to have this brown hyperpigmentation forming, and I guess it could be reduced a little bit with the stocking. And I really regularly make a control of the patients after 2 or 3 weeks. Everybody has to come, and we look if there are some touchable hard places in the vein, and we always, with a number 1 needle, the large yellow one, we make a puncture and express this. Perhaps we can
Yes.
make another session about how to deal with the little ones and with the after treatment, because this is, in my eyes, when you do this, I treat real large varicose veins, if you have seen, and you will
Yes.
have less skin pigmentation if you have them retreated after 3 weeks, making this punctures and expressing the gelatin you have. And there is one
Yes.
very important question also about why I don't give 10 mils in one moment. If you
Yes.
see, it is first, it is prohibited by the German guideline. The German guidelines say you can give 2 or 2.5, full stop, and this is what I do. But I think it is good from the strategic point of view. Only if you do a large saphenous vein and you put a catheter in, then you can of course deliver while you withdraw the catheter, and you can put the 10 mils in one. But if you think of it, you are withdrawing the catheter, and so you are delivering it at different points. You
Yes.
make a higher usage of your sclerosing agent if you distribute it. And
Yes.
so as time passes, the foam will get worse. So it is good
Yes.
to take a little amount, put it in, take a little amount, and so you have always fresh foam and you can distribute it. Yes?
Excellent. Yes.
Okay.
Excellent. That's great.